Hello, and welcome to today's talk on the clinical utility of concussion injury biomarkers. I'm Paul Johnson, an associate professor at Upstate Medical University in Syracuse, New York. Before we begin today's presentation, I want to mention that I have no disclosures, either financial or other conflicts of interest related to this presentation. Three main learning objectives to discuss with you today. These include identifying current diagnostic tools for assessment of acute concussion or traumatic brain injury, TBI. Second, to describe the clinical utility of serum biomarker proteins for detecting concussion injury in human subjects. And third, to discuss serial sampling strategy and reference change value to identify a significant change in biomarker test results. In this first part of my talk, I'd like to begin with brief discussion of definitions and diagnostic tools related to assessment of traumatic brain injury. Traumatic brain injury, or TBI, is a term applied to various outcomes related to head injury, which ranges from mild to severe. The most mild form, subconcussion injury, is limited to neuropsychological findings without structural damage. As such, these are undetectable by imaging modalities such as brain CT or MRI scan. As TBI increases in severity, we have concussion injury, which is usually referred to as mild injury or mild TBI, mTBI. This is transient impairment of brain function associated with injury. Imaging tests are also often negative in many cases of mTBI. Acute subdural hematoma, or bleeding within the brain, is the next level of severity. This is observed 75% of the time in moderate to severe concussion injury by brain CT or MRI scanning. And lastly, chronic injury from repeated blows can manifest as chronic traumatic encephalopathy, or CTE. Tau and phospho-tau proteins accumulate and deposit in the brain, which has been linked to possible development of CTE. Many know that CTE has gained increased attention in recent years, especially among contact sports athletes in professional leagues. This is a neurodegenerative disease which is irreversible. However, for today, I'll be focusing on the first two of these, subconcussion and concussion injury, because these often present the greatest diagnostic challenges. In addition, the hope is that early diagnosis may prevent later development of more severe cases of TBI. Next, I'd like to briefly highlight the growing concern of increased TBI cases. The U.S. Centers for Disease Control and Prevention has reported roughly 2.88 million cases of TBI last in 2014, and this is up from 153 million cases back in 2006, representing a 53% increase in TBI-related cases. These are those presenting to emergency department visits, hospitalizations, or resulting in deaths. The most common cases of TBI include sports injury, combat injury to veterans and military personnel, accidental falls, and motor vehicle crashes. In fact, it's been reported that 50% of TBI cases were due to motor vehicle crashes in a recent paper in JAMA Neurology. Nonetheless, TBI definitions remain the same regardless of the underlying cause. Before addressing biomarker testing, it will be helpful to understand signs, symptoms, and functional tests associated with concussion injury. Common signs and symptoms include suggestive symptoms such as headache or nausea, physical symptoms such as loss of consciousness, loss of memory, vomiting, or neurological conditions such as behavioral or emotional changes, cognitive impairment, or sleep disturbances. Functional testing or non-biomarker testing include neuroimaging, cranial computed tomography or CCT scanning is used to visualize fractures or lesions in the brain post-injury. It is considered to be the gold standard test, and that to which we'll be comparing some of our biomarker tests. And magnetic resonance imaging, or MRI, is also used as one of these modalities. Functional scoring algorithms such as the Glasgow Coma Scale, GCS, or the SCAT-5, the Sports Concussion Assessment Tool, and balance testing or balance error scoring system are also used as functional tests for assessment of TBI. The Glasgow Coma Scale is a point system based on assessment of 3 criteria: eye response, verbal response, and motor response. Scores range from 3 to 15 with the following categories. Severe head injury is defined as a GCS score of 8 or less, moderate head injury with a score of 9 to 12, and finally, mild head injury or mTBI with a GCS score of 13 to 15. So a person may have a perfect score on the Glasgow Coma Scale rating, but still have mild concussion injury. SCAT-5, or the 5th edition of the Sports Concussion Assessment Tool, published in the British Journal of Sports Medicine, has been also used to evaluate TBI. And this is embraced by several sports organizations around the world. It relies on a multi-step approach, which includes the GCS score, as we just saw, with the eye, verbal, and motor responses, plus certain red flag items such as serious neurological or physiological signs and symptoms, other observable signs such as the person being knocked out or motionless, facial injury after trauma, and finally, cognitive testing, memory assessment questions, as well as balance testing are integrated into the SCAT-5 scoring system. With that introduction in mind, I'd like to now focus attention in part 2 on the clinical biomarkers of acute concussion injury. Highlighted here are going to be the role of the blood-based biomarkers. Clinical biomarker tests have been used to detect multiple causes of underlying acute brain injury. Some clinical examples include diagnosing brain injury upon CNS infections, both viral and bacterial, acute ischemic stroke, and finally, concussion injury or TBI. Several different body fluid sample types have been used during the course of both clinical studies as well as diagnostic studies. These include saliva, which is non-invasive but currently limited in applications. It has been used in molecular profiling, such as microRNA patterns associated with head injury. Cerebrospinal fluid, or CSF, is the most direct measure of brain-derived proteins within the central nervous system. However, it's a very invasive sample to collect. And finally, blood samples, or more commonly serum or plasma, are the most popular sample types to use for these biomarker test assays. It is a less invasive collection compared to CSF. And as an indirect measure, serum can provide detectable changes of central nervous system derived proteins. Which qualities make for a good candidate TBI biomarker in blood? Well, in general, these are going to be produced by cells within the brain region. They'll appear in the peripheral blood upon head injury, usually through damage to the neuronal cells. And also, they need to have a good detection time window. So these increases will be detectable soon after injury, and also the elevations will remain above baseline for several hours to a few days after injury. Thus, for these biomarkers, the biological functions are less critical than the physical properties of the markers we're going to be looking at. As such, the focus in this presentation is on commonly studied biomarkers Before we look at those biomarkers, we'll look at one mechanism: injury and release of substances, usually proteins, into the blood after concussion injury, often through disruption of the blood-brain barrier. The blood-brain barrier is formed by brain endothelial cells connected by tight junctions. Trauma to the head may breach the protective layer of the blood-brain barrier. And substances normally produced by neurons, astrocyte cells, glial cells may be released into serum following head injury, and these are the biomarkers of interest to us. And once in the peripheral blood, these proteins will transiently spike in concentration until undergoing normal elimination, usually through renal mechanisms. For this talk, I've included 6 of the most popular serum protein biomarkers used in the field, however, in no particular order. This includes markers with approved clinical use, as well as common research use only markers. While all of them are immunoassay format, the designs do differ across manufacturers in terms of detection and the way that the system is run. Some of these are manual tests, whereas others have become more automated. The first couple that we'll look at recently received FDA approval in the United States for in vitro diagnostic use, or IVD use. These are UCHL1, the ubiquitin C-terminal hydrolase L1, and GFAP, glial fibrillary acidic protein. Other markers shown here have received diagnostic approval outside of the United States, such as S100 beta, the calcium binding protein S100, beta isoform, has been approved in the European Union for clinical use, both for potential brain injury or TBI assessment, as well as a role in non-TBI cases such as malignant melanoma. However, in the United States, this is labeled as a research use only test assay. Neuron-specific enolase, or NSE, is also a popular biomarker. This enzyme is usually used to detect neuroendocrine tumors, such as a neuroblastoma, but it's also had potential clinical use in TBI cases and concussion injury. Myelin basic protein is another popular protein that is studied as a potential biomarker for TBI. However, the major focus of this is usually CSF testing rather than blood testing, and in diagnosing multiple sclerosis, or MS. And it's actually received US approval as a lab-developed test for clinical diagnostics for MS patients. And finally, prostaglandin D synthase, or beta trace protein. This has also been a popular marker in research use only of TBI. Clinically, it's been used to detect CSF leakage into the nasal cavity or ear canal. Highlighted in this slide are the diagnostic performance characteristics of 3 in vitro diagnostic approved biomarkers. GFAP and UCH-L1 from Banyan Biomarkers out of San Diego, California, and the S100 beta test assay from Roche Diagnostics in Europe, headquartered in Mannheim, Germany. As we can see from these performance values, we note that the clinical sensitivity, shown also with the 95% confidence interval around those estimates, are nearly 100% or perfect for all of these biomarkers. I should note that the tests GFAP and UCH-L1 are actually interpreted together, so these values are identical in both the first two rows. The S100 beta assay from Roche has also shown to have high clinical sensitivity, or true positive rate, of 98.8%. On the other hand, the clinical specificity, or true negative rate, is quite low, only in the mid-30% range. This is coupled to the negative predictive value and the positive predictive value of negative and positive test results, respectively. Notice that the tests with the high clinical sensitivity also have very strong negative predictive values, meaning that a negative test will help to rule out the diagnosis of TBI. Nearly 100% in all cases. On the other hand, the positive predictive value, meaning the post-test probability after a positive biomarker result, is fairly equivocal because we only have a 9.2% post-test probability with the first two markers and an 11% post-test probability with the S100. So a positive result from these tests is not very useful and helpful clinically. And as we'll see, it usually means that the biomarker would need to have a follow-up with a CT scan for diagnosis. And I've summarized that in the table shown here, again with the high clinical sensitivity, high negative predictive value as being good attributes of these biomarkers, whereas the low clinical specificity and relatively low positive predictive value are not very helpful. So their tests are going to be good at ruling out the need for CT scan, which can benefit the patient because it reduces costs in the healthcare system and also can prevent unneeded radiation exposure that the patient would need to undergo. In a publication by Papa et al., published in JAMA Neurology, the authors looked at the temporal profile of the GFAP and UCH-L1 biomarkers. They used the Banyan biomarker tests, the BTI test assay, which eventually led to its IVD approval from this study. But what we note here, looking at the upper cutoff values that they had established in nanograms per ml units, shown on the y-axis here, GFAP has a very low upper cutoff value, and UCH-L1 also has a relatively low cutoff value compared to the spikes and rises that we see in both of these biomarkers. And notice that there's a sharp rise in serum levels in both markers after injury, which return to roughly normal or baseline levels after 72 hours. So they're rapidly cleared by the body, usually by renal mechanisms, after they've spiked in this transient manner. So there's a very narrow window in which we can actually use these markers to detect acute concussion injury. And in a pilot study, colleagues and I had looked at two serum biomarker tests, the S100 beta, as well as the neuron-specific enolase tests, in a study group of amateur mixed martial arts fighters. We published information on the study a few years ago as an abstract, and I have the citation here for those interested in reading more about the study design. Of most interest to us were changes at baseline or pre-fight to post-fight levels to see the time course of injury. In a small subset of these individuals, we had also investigated the temporal changes at 4 time points for both of these markers. Specifically, we're looking at pre-fight values labeled as A. These were blood draws taken before one of the mixed martial arts fights. In time point B, this was 30 minutes after the fight had concluded, within 30 minutes. And then we were able to resample these same individuals 72 hours later, and then 1 week after the fight. For this small group of 11 subjects, we noted in the trend increase in the post-fight within 30 minutes after the fight in both markers, with return at or near baseline by 72 hours for time point C. And to put these values in perspective, I've shown the clinical cutoffs recommended by the test manufacturer for both S100 beta as well as the neuron-specific enolase. So in this final part of the talk, we will explore the serial sampling strategy with special attention given to biological variation and reference change value. Given the limitations of diagnostic test performance we've already observed with the high false positive rates, as previously described, meaning the low clinical specificity, there is hope that a serial sampling strategy can offer an alternative way to interpret those test results. To highlight a few selected applications already in diagnostic use for the serial sampling strategy, the first is acute myocardial infarction, or AMI detection, cardiac troponin test measured in blood or serum on a suspected patient having a heart attack. We'll follow a time course, usually at baseline, 3 hours post-admission, and then 6 hours post-admission to look for the trend and changes. This is very helpful as a rule-in and rule-out strategy for someone with suspected AMI, whether that patient needs to be admitted to the hospital, to the ICU, for example. Another use of the serial sampling strategy is to detect acute kidney injury, or AKI. This is indicated when the baseline serum creatinine value in the patient increases by 0.3 milligram per deciliter, or 26.5 micromoles per liter, within the previous 48 hours. So we're looking at a time course of these markers as they change. And finally, the use of the reference change value, or RCV. This aids in post-analytical test interpretation, and it relies on having biological variation estimates of the clinical test marker to calculate the RCV. Biological variation. These data are descriptive measures of dispersion. Biological variation describes a random fluctuation of biomarkers due to normal physiological processes. And this fluctuation occurs around the subject's mean or average test concentration value. And it's been termed the homeostatic set point at that average test concentration value. Measures of dispersion that are used to describe these data are variance, standard deviation, and percent coefficient of variation, or relative standard deviation. Those variance components are separated out using the analysis of variance, or ANOVA test. And biological variation databases include information for a multitude of clinical biomarkers. I've included the links to both of these databases, the first from 2014 on the Westgard QC site. These are provided in a table format. And the European Federation of Laboratory Medicine and Clinical Chemistry has a more updated database from estimates in 2019. And these are searchable by test marker as well. Illustrated in this figure are the two components of biological variation. I've shown this with an example of the S100 protein and the concentration on the y-axis in picograms per ml. The observed variation of the test result between subjects is referred to as the CVG, the coefficient of variation of the between subjects, or the group variance. and the within subject variance, or CVI, shown here. So for each one of these subjects, that range will be the CVI in these 12 subjects. We determine the CVG and CVI estimates from repeat sampling of healthy individuals, and in this case, we're speaking of non-concussed individuals. And this figure represents 8 separate measurements from 12 subjects, with a plot of the 8 individual values shown in the gray dots and the mean value for each individual shown with the blue dots. And note that all these values are within the interpretive range, much less than 105 for the upper cutoff, and the median values were in fact 48 picograms per ml. In a subset of subjects having repeat blood draws in our study, my colleagues and I had looked at the normal baseline or pre-fight time point concentrations in order to calculate and estimate the within-person biological variation, the CVI, for both the S100 and NSE biomarkers. Further, the RCV or reference change value calculation shown in the table was used to calculate that significant change cutoff value. Of note, the RCV provides individual diagnostic assessment in place of population-based reference interval cutoffs. So instead of using the 105 cutoff that I just mentioned for S100, here we're going to be using a percentage change, or RCV, to determine significance. And from those calculations, we can see that a one-sided RCV gives a significant increase of 44.1% or greater for S100 beta and 54.1% or greater for the NSE protein. In order to determine percentage change, we apply the formula shown here, which is the patient's current result minus their baseline result divided by the baseline result. Then we ask, what is the probability that the percentage change in the test value from baseline is significant? Well, this can be determined by comparing to the 95% significance RCV value based on biological variation data. The benefit of the RCV is it may allow for increased detection of positive results. From 87 paired samples, baseline to post-fight, we compared the clinical cutoff values using the population reference interval established by the manufacturer in panel A, and compared that to the percent change significance based on RCV in panel B. Notice for the NSE test, the percentage of individuals who went from a pre-fight negative value within the reference interval to a post-fight positive value was 27.6% of the fighters. However, when we compare that to the significant RCV values, we observed that 49.4% of the fighters now had positive changes. And the same thing occurred with the S100 protein. 54% were flagged as positive based on the reference interval alone, whereas using the RCV calculation, we observed 86.2% who were positive. So again, this highlights the fact that the use of the reference change value can allow for better detection and interpretation of positive test results, one of the limitations currently of the biomarker tests that we have in use. I'll finish with a few concluding remarks based on what we have looked at in this presentation today. First, correctly identifying acute mild traumatic brain injury remains a continuous clinical challenge. There are diagnostic challenges of the observational and functional tests. Many of these rely on clinician subjective assessment, such as the Glasgow Coma Score rating. CT scans often are negative in mild concussion injury. Serum biomarker testing offers additional tools for the clinician. Diversity of brain-derived protein biomarkers have gained increased attention in the field. These are released into the peripheral blood after damage to neuronal cells, and it's usually a transient increase, went back to baseline in roughly 72 hours as we have observed. And current biomarker tests exhibit low false negative rates or high clinical sensitivity, but unfortunately suffer from poor clinical specificity. Therefore, the serial sampling strategy may allow for improved diagnostic accuracy. That strategy compared the result change between the last two tests that the patient had to interpret as positive or negative. And this is based on comparing to the 95% significance level or reference change value based on biological variation estimates for the test. Thank you for attending and listening to this presentation on clinical utility of concussion injury biomarkers. If I can help answer any questions, don't hesitate to contact me at my email address provided here.